Check, check. Hello, mic testing. Check, check, check. Hello, hello, hello. Check, 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 check. Hello, hello. Check, check. Mic testing. Check, check. Hello, hello. Check, 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 check. Hello.
we'll start with our next session. We'll invite Dr. Rajavardhan Rangappa to speak on filtering sepsis, which one and when to use. So, again, like biomarkers, we had lots of available in the market. We'll try to understand that. For this, we'll invite Dr. Padmanabhan S. and Dr. Dayanand to chair the session. Please come on. Dr. Padmanabhan is Chief Nephrologist, Head of the Department in Sagar Hospital, Bangalore. Dr. Dayanand is our consultant in Department of Nephrology, Kaveri Hospital, Electronic City. So, over to you, sir.
Sepsis, I think we all know, is one of the leading causes of death. I think it is going to probably go hand in hand with the non-communicable diseases over time. We are running out of antibiotics. I don't think there are any major antibiotics or antifungals in the pipeline to help all these patients. One aspect is the organism causing damage, but what is more important is the cytokine storm it elicits, and these cytokines cause devastating damage. So I think we'll have to address that also if we have to treat sepsis successfully. So we have a lot of filters available, very exciting. We were initially using high volume hemofiltration. Now we have very focused adsorption filters where it specifically absorbs these harmful cytokines which cause the hemodynamic problems in sepsis. So let us welcome Dr. Rajvardhan to address this issue and throw us more light on how to go about when we are at a situation where we need to use blood purification for sepsis. Dr. Rajvardhan, please.
Thank you, sir. He has given most of the introduction already before I start on my topic. So before starting, I just want to know, anyone of you have used filtering in sepsis or any absorption? Which one you have used? You tried everything. Okay, it's nice to know. Okay. So before going to filtering in sepsis per se, what I want to understand is most of the time death in sepsis doesn't happen due to infection per se. It is due to dysregulated inflammatory response. That's the major cause of death than the infection per se. So in sepsis, that's why the entire definition now has changed. It is known as life-threatening organ dysfunction caused by dysregulated host response to infection. So before going into the filtering per se, we know that the sepsis per se has gone a lot of refining treatment per se. So we are somewhere the mortality was almost 50%. We are able to bring down the mortality almost to 30% at this point of time. It's mainly because of these three things. One is resuscitation, second is antibiotics, third is resource control. These are three most important things you are going to do in sepsis. But beyond this, our hands is tried. So from ages, not from now, from ages, there are lot of treatments have been tried. Out of that, one aspect I'm talking about is filtering in sepsis per se. So before going about evidence or what exactly are those things, better to understand the pathophysiology or understanding of what exactly happens in sepsis. So in sepsis, 1 minute. Sorry, one slide is missing. Okay. So in sepsis, initially, whenever the sepsis starts, it can be divided into pro-inflammatory and anti-inflammatory. Whenever there's an insight of infection is there, these bacteria per se, as well as endotoxin associated with that, will suddenly cause a inflammatory response. Okay. These inflammatory response can be in the form of TNF, interleukin 1 and interleukin 6. These are known as pro-inflammatory cytokines. Okay. So these are the one which will cause sudden cytokine storm in the body. Okay, whenever these levels are elevated, patients will go into sepsis. Along with it, not only pro-inflammatory cytokines, there are something known as anti-inflammatory cytokines also. There's a body's response to that. To prevent this inflammatory response, body will have a anti-inflammatory response, basically in the form of interleukin 1, TNFR and interleukin 10. These are anti-inflammatory cytokines. So what exactly happens is, there's something then a toxic threshold or cytokinic threshold. Beyond this, if it is too much, beyond certain level it goes, it will cause sepsis. Okay, if pro-inflammatory response become too much, it will cause overwhelming body response, causing multi-organ failure, causing sepsis. Whereas anti-inflammatory response too much will cause immunoparalysis. Suddenly, patient will be devoid of any immune response. So they are high prone for developing infection. Our goal is whether we can stop going into this phase, excessive pro-inflammatory as well as anti-inflammatory. Both we are trying to stop here. Okay, so in filtering in sepsis or blood purification, what we are trying to do is, as you can see, this is at the tissue, this is at the blood level. In tissue level, there are a lot of bacteria are there, cytokines are there, leukocytes are there. So it will invariably spill over to the blood, causing all these things in the excess in the blood also. So what we try to do here is, we try to do something known as blood purification or filtering to remove these things, so that what happens is when we remove these inflammatory response, it will lead to less inflammatory response at the tissue site. Indirectly, less cytokines, less leukocytes, less bacteria in the blood invariably. So that is what the hypothesis is. Sorry, I'll just change. So cytokines, it comes in various sizes. It can be small, it can be medium, it can be large. So before discussing about the sizes, okay, there can be small molecules. Example, less than 500 kilodaltons in the blood. It can be urea, it can be electrolyte and phosphorus. These are the things which we remove during regular dialysis. Okay. So middle molecules, it is varying size from 500 kilodalton to 15,000 kilodalton. It is basically beta 2 macroglobulin, interleukin 8, interleukin 1, C3A, C5A. So large molecules, more than 15,000 kilodalton, it can be myoglobulin. Your interleukin 10 and 6 and TNF alpha will come here. These are large molecules. If you try to do more than this, there are a lot of essential proteins like proteins which are in the blood. There's a possibility if you try to remove more of this, you might remove a lot of proteins also from the blood. So to remove small molecules, you need a low flux dialyzer. Example, whatever you use during regular dialysis. So to remove middle molecules, you need an absorber, means something which can absorb the molecules within the blood, or you need a high flux dialyzer to remove slightly higher molecule. So to remove larger molecules, which include interleukin 10 and interleukin 6, something like that, you need an absorber or hemofiltration. Okay. So depending on this, so there are a lot of the different members are there. That's what I spoke about. Low flux we are not talking here. High flux membrane, which has a very less than 0.01 micron. So high cutoff membranes, which has a size of less than 0.02 microns. For protein separation per se, example in case of multiple myeloma or something like that, you can use 0.09 micron size. Last, for a plasma filter, like plasma pheresis, use 0.3 micron size. Basically, it works by convection. So, per se, depending on, this is about the pathophysiology per se. So, how we are going to remove it? I said there are cytokines are there, are inflammatory molecules are there, are endotoxin. How we are going to remove it? So, there are basically two main techniques are there. One is adsorption, where your membrane will contain certain things which will absorb the endotoxin or cytokines which are possible, which are responsible for inflammation. Next, in convection based, we are going to remove cytokines from blood per se. It includes high volume hemofiltration, plasma pheresis, or high cutoff membrane based. Both is coupled plasma filtration absorption, then oxidase. So adsorption based, as I told you, there are three techniques mainly. There are multiple filters are there in the market. So basically, we are talking about three things. One is toramycin, cytosorb, Alteco, LPS. Convection based, I discussed already. In both, I think nowadays oxidase is more available in the market and it's becoming more popular. And CPFA, these are two techniques. So I want to discuss only on certain important aspects. So example, first I'll go to toramycin. So this is initially before they applied, they did a in vitro studies basically. So in that, what they have done is they measured the endotoxin level. Okay, this is the endotoxin level. If we, without any toramycin cartridge, endotoxin levels remain very high. Whereas when they applied a toramycin filter, it decreased in the size, there is a significant decrease in the level of endotoxin. So there have been numerous studies which has come in the field of uh, polymyxin B hemoperfusion or toramyxin per se. First was UFA study. I'm not going to detail into old study. UFA study, where they found that there is significant mortality benefit of that. So it has come in 2009 around. Suddenly there was a lot of gain in the interest. A lot of people started using it. Uh, then in the meantime, Abdomix study came, which is in 2016. There they found that there's a trend towards increased mortality was there. So that is kind of not considered. Finally, the recent most study is Euphrates study. Here, basically what they did is they compared when they used the filter, they compared the mortality versus group uh, uh, with sepsis. Basically, they used MOTS level more than 9. If it is there, they would have compared. So in that, they found that there's no difference in the mortality if you use a polymyxin filter was hemoabsorption versus no filter. So as usual, whenever we find that there's no difference, what we do, we did again. We thought that we'll analyze study again. They did a post hoc analysis of the same study. In that, they found out that a subset of patients which has got endotoxin level between 0.6 to less than 0.9 unit had got a mortality benefit if the level of endotoxin level is 0.6 to 0.9. So that's why they felt that we need to do a further analysis of this study and see how the things will progress. So there's right now at this point of time, there's a study by name Tigris which is ongoing to study whether if it's efficacious or not. At this point of time, I'll discuss about later when to apply, how to apply. Then one more important which has been used especially in case of COVID and post-op CFG cases, cytosol as well as in sepsis. It is also a high-tech polymer. Here there will be absorber beads will be there, okay, which will absorb cytokines. So here, as I don't know, whenever the new technology comes to the market, whenever they study, initially there are very good response. Basically, those are single center studies or observation studies. In this also, there are a lot of initial studies, single center studies. So there's a good mortality benefit. There's a good benefit in the terms of survival. Most importantly, they noted that the vasopressor multi-organ failure incidence was less. Vasopressor requirement had come down. Recently, in 2023, there's one meta-analysis published. In that, they found that there is no mortality benefit per se, but there was a sorry. Before this, they said there is all the studies have shown that, especially RCTs, there is no mortality benefit per se, but it is kind of beneficial in terms of decreasing the vasopressor response or organ-free survival duration was better with cytosorb. So in 2023, one study came. In that, they found that there's no mortality benefit per se. It's a systematic meta-analysis, systematic review and meta-analysis. They found that there's no mortality benefit, but you can use it if you want to consider decreasing the cut down in the dose of vasopressors or organ-free survival. So these are the studies related to cytosorb. Next, I discuss about mainly absorption. Next, we'll go to filtration per se. In the absorption, what they've done is either first thing they tried endotoxin absorption with cytosorb. Second thing with cytokine absorption with hemoperfusion with polymyxin B. Next thing they tried is whether filtration. As we know, as I told already discussed, in case of sepsis, there's an increase in inflammatory, pro-inflammatory as well as anti-inflammatory cytokines will be there. Whether removing this per se both from the blood, whether it's going to benefit or not. So they've done a studies where initially they compared versus normal hemofiltration versus high volume hemofiltration. There they found 35 ml per kg. In there they didn't find much benefit. Where then they did a ivory study where they compared high volume versus very high volume ultrafiltration, high hemofiltration. In this also they didn't find any benefit per se. But as usual, most of the studies when initially came, no, there is a single center study, observation study, they found that some mortality benefit, some increases, decrease in the vasopressor dose was there. But recent trial in case of high volume hemofiltration are not good. Some of them have showed increased mortality is there, so nobody is using it at this point of time. But if patient is having a CKD or AKI ongoing dialysis, you can consider doing high volume hemofiltration. Next, couple plasma. Next is hybrid technology. So in hybrid technologies, there are two kinds are there. As I told you, one is coupled plasma filtration and absorption. Here, what they do is using plasma filter. Initially, they remove the plasma. Okay, example, excessive cytokines are there. They'll remove it. Then they'll pass through an sorbent. Basically, it's an absorber. It absorbs some of the inflammatory cytokines. and remaining will be passed again to the patient. There will be one more hemofilter. As you can see here, it involves 3 hemofilters. In that also, there's 2 studies came, compact 1 and compact 2. Compact 1 was equivocal. Now compact 2 is in process. We have to see how compact 2 will benefit. Here also, kind of studies are not good at this point of time. Theoretically, there is a benefit. Last one is Oxiris. Oxiris is basically, it has a 3 membrane. One is heparin membrane, then polyethylene surface. They have done a polyethylene surface treatment, and EN69 membrane. Basically, it has to it acts by 2 technology. As I told you, endotoxin absorption and hemofiltration. Both techniques are involved in this. Here, as we know already, in case of inflammatory response, especially in COVID-19, they found that interleukin the 6 levels decrease. Okay, but whether whether it decrease the mortality or not, we are not sure. It didn't decrease mortality that much. Whereas see, in the lab perspective, when they check the interleukin 6, if you do an Oxiris, definitely it will come down. If you check the cytokine level after doing that, it will come down. Whether it will reflect on mortality or not, still not sure. But recently, there are small studies which have shown benefit. But recently, in July 2023, we got a meta-analysis done. In that, they found that there is a mortality benefit with Oxiris. They compared 7, 14, and 28-day mortality, as well as the SOFA score and norepinephrine dose. All these things were better at 28 days. But when with the same studies, they progressed to 90-day mortality, there is no difference per se. Mortality at 90 days. And the problem with this, most of them are RCTs, most of them are observation studies. RCTs have very few patient size. So once again, if you are using it, so toramexin you have to use, it is mainly for, as I told you, endotoxin. Cytosorb is mainly for cytokines. HA330 is mainly for cytokines. Oxaris is for endotoxin and cytokines. LPS absorber is mainly for endotoxins. So prescription is you have to use toramexin 2-hour session daily for 2 days. Cytosorb up to 24 hours daily for 2 to 7 days. HA330 2 to 6 hours daily for 2 days. Oxaris along with CRRT to be titrated. LPS absorber 2 to 6 hours, usually 1 session. So these are the summary of all the articles which have been published. The recent systematic review is not included here. It started with initially high volume hemofiltration. Initially 1999 and 2002, this study showed that there is some benefit, plasmapheresis as well, high volume ultrafiltration. But after that, there have been recent studies have not shown much benefit per se. So from the absorption perspective, cytosol, definitely it will cause the shock reversal. It is known to improve the shock reversal, but there is no mortality benefit per se. Then when it comes to polymyxin study, as I told you, Eupras initially showed benefit. Abdomex has got increased mortality. In Euphrates, there is no difference in the mortality, but in post-hoc analysis, you noted that endotoxin level 0.6 to 0.9 has got a mortality benefit. But that also now Tigris study is under process. We have to see how it goes. Hemodiafiltration. Initially, studies showed more of improvement in the hemodynamics, but overall, at this point of time, there's no recommendation per se. Most of them have not got much benefit. We have to see about compact to how it process. So, see, as you understand, there's a sepsis. There are a lot of up and downs are there. Example, if you study protein, albumin is less. If you assess vitamin D deficiency, will be there. Or if you consider sugars are high in the sepsis or inflammatory cytokines. So initially, whenever the study start, our tendency is to treat whatever it is more, okay, in the body. Example, sugars are high. Initially, we started treating aggressively, but then we later realized that, oh, we might be causing more harm. We come down on that. Our target from 80 to 120, we come up again to 140 to 180. Now the studies are further going towards whether we have to control or not. Some studies says that more than 180 you can target if HbA1c is high. It has come to a position like that from the glycemic control. From the inflammatory reaction per se, see, body has a response for certain reason. Okay, all the cytokines, basically it is a fight against. Sometimes we feel that it's in excess, we try to do all these things, but doing that we may cause some harm. They have a role in the body, that's why they're high. But even if you want to do it, we should find because whatever is, it's more of a generalized example. We are not removing a specific cytokine, we are removing all the cytokines. There are some cytokines which might be beneficial, some cytokines which might be harm. That way we might cause in certain situation more harm. If we want to use it, at this point of time, oxyrase is kind of endotoxin removal. I can understand because it makes sense. It is produced by a bacteria. It is not produced by our body. If you want to remove something which is produced in our body, we should think twice whether it may cause harm or not. At this point of time, even the studies have not find more harm, it is not found more benefit also. So even if you want to consider at this point of time any of these filtering techniques, you want to consider from the perspective of understanding of the physiology, how much you want to know, okay, with an understanding from the research perspective, you want to understand how body responds. Example, if you use cytosorb or oxyrase, immediately found that within a day or two, there is a decrease in the shock, there is a organ free, this thing is there, but eventually these things won't convert into mortality benefit because there's just body's response. You're cutting down the body's response. Even our steroids also does the same. What does steroid has done? It has decreased the period of shock per se, decrease shock free, but it will not benefit from the mortality perspective. So whenever you want to use all these things, you have to consider from a holistic approach. If you want to use it from a research perspective, definitely use to understand the pathophysiology of sepsis. Definitely people who use this in their unit, they have better understanding of the pathophysiology because they know what they're doing. So from the learning perspective, you do it, but don't use it just for the sake of using it. That's what I'll say. So right now, if you sum up all this evidence, in case of severe sepsis, septic shock, if there is an indication of RRT with AK, if there is an indication, you can consider a high volume hemofiltration. Without AK, if there is an endotoxemia, if endotoxin level is 0.6 to 0.9, you can use polymyxin or oxaris. If there is a cytokine storm with interleukin 6 level more than 1000, as I told you, you should have evidence. I don't say that using this monitor, if you measure interleukin 6, it's not going to change the treatment, but you should understand what you are doing. If interleukin 6 level is very high, you can consider cytosorb or oxyrase, but how much it will benefit from the mortality perspective, nobody is sure. We have to evaluate for further studies and see how it will benefit. That's it from me. Questions? I know it's a difficult topic.
Can you take? So Raj, it is a storm. It's a cytokine storm. There's
Yes.
a huge amount of cytokines getting released. So how will we be able to take off that much of cytokines with this small filter? That is one. And adsorbent, whatever gets adsorbed, will it get re-released into the bloodstream after some time? And the third one is, as you rightly said, you cannot remove all the good ones. If you remove the good ones, then you cannot fight the sepsis.
See,
So how do you justify this?
See, endotoxin, somehow we can still try to justify physiologically. Cytokine removal, even if you do as you said, it will act for just 6 hours. After that, they have seen that there is a rebound increase in the cytokine level. Body will produce. Once it is removed, there is a rebound increase in the cytokine levels are there. So that's why whatever the response, whatever the organs are free, whatever the shock free, it's all transient. After that, again it will come back. So that's why I told you, I per se I'm against that. Okay, but for an understanding perspective, from the pathophysiology perspective, from understanding the sepsis perspective, if you don't know all these things, you don't know. Okay, because that eventually this will give to more ideas. If you don't do these studies, you'll not understand what's happening inside. It will give to more ideas. There might be a new molecule. It might we might direct it. So I'll definitely don't say don't use it, but if you want to use it from the understanding perspective and monitor it. A lot of studies have said that even though there is a reduction in the interleukin 6 when you are doing this thing, but level will rise immediately when you stop it. It will rebound increase, which is more than what it was before. There are some studies which clearly says that, but just for understanding perspective, you can still use it. That's what I'll say.
One thing is, like all these filters, they targeted a different like stage in the same spectrum. Some like endotoxin in the beginning, some like its impact on the cells, that is a cytokine, some together with endotoxin and that of the cytokine. But as it clearly elaborated, so we are not able to get a proper RCT on this iron therapy. That is not going to happen. So it is not justifiable by ethics also. Suppose you randomize one group to cytosar, which is 90,000. So one group to non-cytosar or maybe oxaris, that data very difficult to accumulate, difficult to come up with. Because if you see Euphrates study and all, it came from Japan, Korea and all. Because in those countries, so that is been included in the national insurance scheme. So all these therapies. That's why they are the only people they are able to generate data. In India, suppose it is a cytosarb, we have a national registry. Means we can contribute. Okay, I use it in this particular patient A. So this is our case scenario. This data will give. So they accumulate the national registry and it comes out as an observational study. But as we clearly understood, see, most of the targeted data is physiological parameter endpoint. Okay, we used. So how early we are able to come down on like noradrenaline, how early we are able to extubate a patient, and some data they looked particularly this cytosarbandal. Another parameter they looked was like PF ratio, PaO2 by FiO2 ratio and all. But still, the $1,000,000 question is like, okay, we have a spectrum of sepsis or septic shock. So should we use with an RAD of 2 ml, 3 ml, 5 ml? So we don't have an objective criteria. So it's like, okay, I am an expert in the rounds. I'll tell, okay, this patient will put Oxaris because he's in septic shock. So we suspect both endotoxemia and cytokine storm will put this. Otherwise, we don't have any idea. Okay, so we have this checklist. So lactate is more than 3, NARD is more than 5 ml, PF ratio is less than 100, heart rate is more than 120, MAP is less than 65. You club together, and if the sum score is like this, then we put a cytosar bar Oxaris. That data is very difficult to generate. But cytosar make one attempt to look all those parameters. They came up with some protocol. So you consider some biochemistry, some data on PF ratio, some biomarkers, including they added like CRP value and that of the procalcitonin value. They tried to give one value, okay, 0 to 3, 3 to 8, more than 8. More than 8, the probability of benefit may be very, very low because they are in a very severe irreversible state. So 3 to 8 is the score where we can apply. Again, roaming around, so we come back to understanding no data to support all these physiological endpoint improvement has been translated in reducing the mortality. But if you ask me, like, should we abandon using? Answer is no. Okay, because one filter which you can fix for cytokine and endotoxin, and the same filter which we can continue, as in like dialysis filter, that is Oxaris, so that can be used. And among all the data, a bit of good quality data, good quality evidence is favoring towards Oxaris.
Oxalis.
So if you really want to use, where we can fix cytosarb, see, patient is a severe acute pancreatitis where we expect only a huge cytokine storm kind of this one. So pancreatitis is not an infection; it is a very bad inflammatory surge. So we can. And for your question, okay, suppose you used cytosarb for 3 hours, 4 hours, or maybe 8 hours, 10 hours. So what next? Next day patient can have. But see, that is a dynamicity. The burden of release of the quantification of your cytokine may not be same on after 24 hours. By that time you done your resuscitation good, you started him on antibiotic or some sort of source control has happened. So basically this idea is we want a more time to make the patient life sustained so that your other therapies are going to match up. So it is obvious. Means like suppose you stop the filtering. So Oxaris is the one filter which you can continue. Means like as long as the patient require dialysis, the same filter work as a dialysis filter after your initial 2-3 hours of removal of your like endotoxins. But that additional time, if you reduce that burden, that repetitive injury, because it's a vicious cycle. So by during that time, you take care of all other parts of your resuscitation, source control, optimizing antibiotic, escalating antibiotic. So that helps. So that is the only take home. Thanks, Dr. Rajwardhan. Any comments?
Okay. This, if you want to see, this is a slide. You should actually, I missed the slide, so I put it now. This is where all this different modality of treatment will act. Okay.
Thank you so much. So we'll invite Dr. Himal to hand over mementos to our speaker and chairperson. lecture, we have one important session that is on managing a post-renal transplant patient in critical care unit. I invite Dr. Rohan, Agustin, and Dr. Madhusudan to chair the session. We have a speaker, Dr. Himal Dev, who is currently heading the Department of Critical Care Medicine in Apollo Hospital, Sheshadripuram. So,
So good afternoon. Those who are sleeping, please wake up. I have a very few slides. So my topic is it's okay. So management of post-kidney transplant patient. So the two things which makes it easy is if you have a good nephrologist who can select the appropriate cases and a good surgeon who can handle it well. Post-operatively, things become very, very easier for us. How many of them are intensivists here? All are intensivist, okay, nephro-intensivist. So if you look at this, this will be a wake-up slide for you. The comic which was put, I think a few years ago, just mocking that it is not possible. No, pig kidney donation, xenotransplantation. So, but if you look at today's scenario, it has happened. I'm sure you would have read in the paper, the xenotransplant has been done for a brain dead donated patient, and it's been run well for 2 months. Okay, so that's where the transplant is at right now, and that's why we need to know how to manage these patients well. Just a small slide, just in showing the gender differences. If you look at it, men have faster progression of CKD, and they have higher incidence of end-stage renal disease, and they get transplanted more often. But unfortunately, women are less likely to be listed. They wait longer once listed, and they always on the giving side. So women donate more kidneys than they receive. Okay, so let us go to the proper topic. This was an excellent article which was published in Intensive Care Medicine 2019 by Michael Darman, and I've taken tips from here, and everybody should go back and read this thing so they can learn how to optimally manage the transplant patients. Okay, so this is, so if you know what are the complications to expect, then only you can handle it better. Few 3 slides just to saying what all to be expected. Okay, so acute bacterial graft pyelonephritis is the most frequent type of sepsis which is C, that is caused by bacterial infection. Urinary catheters and ureter stents are the common risk factors here. So here the renal imaging to rule out UTIs, urinary tract obstructions, renal abscess, and urine leakage helps. The second common infection would be bacterial pneumonias. So that completes the bacterial part. When you go to viral and fungal infections, notorious cytomegalovirus disease. Nowadays it is decreased because of post-transplant prophylaxis and preemptive strategies. But viremia can be life-threatening. It can cause retinitis, it can cause pneumonia, it can cause colitis, and it can also cause meningitis. So in these notorious. Otherwise, influenza, RSV, and adenovirus can cause viral pneumonia. BK virus can cause nephritis, ureteral stenosis, and hemorrhagic cystitis. Epstein-Barr virus also causes post-transplant proliferative disorders. And fungal infections, we have not so common, but pulmonary aspergillosis and candida, it can be rare. Candida can cause mycotic aneurysm of graft vessels, but it is rare, but if it happens, it has got a very bad prognosis. So that's about the infection, bacterial and viral and fungal. Then the other second tip would be, you should know the anti-rejection drugs and their complications. So you know the different kind of drugs causing different kind of complications. They can cause pneumonitis, press, and thrombotic microangiopathy. And sometimes these drugs can also cause neutropenia. And if you start when the patient simultaneously has a sepsis and you decrease the dosages or you stop the dosages, you can actually increase the chance of rejection. And most important thing is the drug interactions. If the patient is on an azole or if the patient is on a macrolide antibiotic, actually you're actually tampering with the concentration of your immunosuppressive drugs like tacrolimus or cyclosporin. Okay, so two things are over, 2 tips. The third tip, intensivist nightmare, the vascular access challenge. Okay, you can see the thrombus here. Wherever you put the probe, there is a thrombus because a lot of access has been taken. So what you need to know is, Try to avoid the subclavian. You can preserve it for next permacatheter also. Preserve the AV fistulas, and post-transplant, avoid the graft side femoral access because you can damage the anastomotic vessels. Long-term complications of CKD includes cardiovascular disease and renal bone disease. Why cardiovascular disease is important is because this attributes to almost 50% of mortality in 1 year of post-renal transplant. So why I have said this is because we have recently lost a patient who did well post-transplant period. On the day of discharge, went home. He insisted on climbing the steps to the first floor, had a massive MI and died. So that's how bad the cardiovascular mortality can be in these patients. So summarizing all these tips, I've put it across the slide. So if the patient post-transplant comes with you to acute respiratory failure, think of the bacterial infections or pulmonary edema because of fluid loading, some of the opportunistic infection which can happen later. He can come in shock, maybe because of sepsis or because of cardiogenic shock, cardiovascular complication, or post-transplant bleeding itself. Drug toxicity elaborately described. Steroids can cause infection, adrenal insufficiency. Calcineurin inhibitors can cause AKI and thrombotic microangiopathy, and the other ones, the common drug complications. But here in this slide, what you need to know is the acute kidney injury post-renal transplant. Very beautifully summarized in this particular slide. See, this is a time course of post-transplantation and how the acute kidney injury develops in them. Okay, so you need to know this to treat the patient. So within 48 hours, it can be because of ATN, acute tubular injury, maybe because of reperfusion injury post-transplant, or because of hypovolemia because of the bleeding, or intra-op hypovolemia. Then immunological complication is nothing but the rejection, which I'll going to tell you in the further slides. Surgical complications because of bleeding or vascular complications like kinking of the vessels or any thrombi in the vessels, ureteric obstructions or urinary leak. This needs to be kept in your mind. Then, of course, the nephrotoxic drug exposure, if the radio contrast is given, that also attributes to it. Okay. Then, after 48 hours to 1 week, then the other complications will be responsible for the acute kidney injury. That is, infections. This can happen in the first few days also. Thrombotic microangiopathy and recurrence of primary renal disease. So now we know what are the causes for acute kidney injury, delayed graft function in a post-transplant patient. So the thrombotic microangiopathy is one of the serious complications, and the de novo thrombotic microangiopathy is related to one of the immunosuppressive drugs. Okay. So now you know what are the complications we expect, but as an intensivist, post-transplant, what are the things we need to remember? So always be friends with your nephrologist. Keep close liaison with the renal team about the perioperative plan. If possible, optimize prior to the surgery. Get a cardiac opinion, optimize the cardiac status, sugar status, blood pressure status. Okay. Note down the intraoperative event. Very, very important. Most of the times we don't get the handover properly. What has happened intraoperatively? Okay. Strict asepsis to be maintained. Avoid hypovolemia and hypotension. Avoid nephrotoxic drugs. And most important thing is the fluid management. Okay. I have two good slides which can explain you exactly how to do it, and multidisciplinary team input. What are the history, like when the patient comes to you to the ICU, what all we need to note down. Okay. So here you need to ask for the graft anatomy. What you need to ask for the history. Any back pain surgery happened, like the kidney was taken out, perfused outside, and what the surgery was done. Any renal capsular tear which can actually cause problems with the kidney function later on. And after the appearance of the cross clamping release, what is the appearance of the kidney? And any intraoperative Dopplers were done, was there any decrease in the Doppler flow? Again, hemodynamic, whether there was a gross hypotension at any time, or did we give a lot of fluids at that time? Fluid balance, the same thing. Input-output chart is very, very important. How much has gone in, how much has gone out. The last one is biochemistry. Sometimes they use insulin dextrose. So electrolyte imbalances and post-operative renal parameters needs to be taken care. Okay, this is what we need to do as soon as the patient comes post-transplant to the ICU. What is the role of imaging? As I told you, any surgical complications or anatomical challenges like multiple renal arteries, difficult bench surgeries, or renal capsular tape should be communicated by transplant surgeons, I discussed. If available, intraoperative Doppler assessment should be documented to look at the post-perfusion flow parameters. Dr. Nadesh beautifully explained post-transplant resistive index role also. That also is being done. And if there is a perioperative concern of allograft perfusion or a sudden oligoanuria, an early ultrasound Doppler to be done, which can detect a lot of things if there is a decrease in perfusion or if there is any blockage in the renal or the renal artery or the renal vein. Okay. So renal imaging is very, very important post-transplant. So just summarize what are the complications which can happen early and late so that we can tackle early. Post-operative bleeding to be noted. Renal artery thrombosis, where you can get a high blood pressure, sudden droppage in the urine output. It needs immediate surgical intervention. Renal vein thrombosis, they can present with fever, pain, high blood pressure again, proteinuria, and usually get settled with anticoagulation. Then infection, to look for any abdominal collection, and also you have to rule out the urinary obstruction. Suddenly what happens, urine output is coming, the next hour output is nil. So that's where your brain should work, get an ultrasound, look there is any obstruction, okay, and get it corrected. If there is acute rejection, then you have pain, fever, high blood pressure, and you have the protocol of getting a biopsy done and find out what kind of rejection it is and treat it accordingly, okay. Then the late complications are the chronic rejection, infection, and side effects of immunosuppression, which we don't deal it with now, okay. The most important slide, few slides, I'm particularly fond of this topic, the fluid management. So before, what we used to do was the goal-directed fluid therapy. So we have certain goals, we have a CVP, we have the values, map values, all those values, and you give fluids accordingly. But when you do that, you actually overload them with more fluids. So nowadays the strategy is flow-directed strategy. That means you have to maintain the perfusion. It's nothing but cardiac output determined. You know the cardiac output, you optimize the cardiac output. When you optimize the cardiac output, you optimize the renal perfusion and decrease the delayed graft function of renal transplantation, thus improving the outcomes. So, and generally a restrictive fluid strategy should be avoided in renal transplant patients, but doesn't mean that you load them and make them a Michelin. Okay, so don't overload them. Avoid the volume overload. And how do we do it? So don't target the CVP or a blood pressure or the MAP. They're all static parameters, and it doesn't indicate the fluid responsiveness. So what we generally do is the dynamic indices, which are our favorites, okay? So generally we do the cardiac output and look at if there is invasive monitoring, we look at stroke volume variation, if there is a possibility of passive like rising test or inexplicable oxygen test, look at the cardiac output response to fluids. I give fluids, there's a 10% increase in the stroke volume of cardiac output, I can give more fluids to him, okay? Do not look at CVP, do not look at MAP, or do not look at blood pressure. Sometimes we can use IVC. It's not a great dynamic parameter, but still it suffices. Or you can do echo and look at kissing LV signs or LV is empty, and it will guide you at the fluids. If it is not there, then a simple lactate clearance or a capillary refilling time, that will only suggest us to give how much fluids to be done, okay? So this part is very important. The next is, you have seen multiple times, we have seen patient starts pouring out urine post-transplant. And you start giving fluids and fluids and fluids, you will drown him with more fluids. So what is the reason for this is, there is a rapid increase in GFR post-transplant in a kidney with malfunctioning nephrons due to pre-transplantation ischemia. So then there is a polyuria. It can also happen because of the over-administration of fluids, kidney is putting out more urine. Sometimes hyperglycemia can contribute to it, okay? Because of all this, they can have hyponatremia because of polyuria, hypokalemia, hypocalcemia, hypomagnesemia, hypophosphatemia, and metabolic acidosis. Of course, if you give a lot of saline, it causes hyperchloremic metabolic acidosis. So that's why polyuria management is very important. Each institution has a different protocol, but generally, if it is more than 1 liter per hour, they continue the infusion of 100 ml per hour, and if it comes up to 100 ml per hour, then slowly they start replacing the previous hour's urine output, and that's how you manage the balance. So don't overload them. If you overload them, you're going to cause more polyuria and more fluid overload. And what's the problem with fluid overload is, all the tissue becomes edematous and it causes other organ damage as well, okay? So this is a slide which actually shows us the more fluid balance, actually more chance of end organ dysfunction, okay? So now, giving fluids is easy, but what fluids to be given? So what fluids do you think to be given? Do we give saline? Do we give plasma light? So, to answer your question, so this has come the long way from normal saline to the balanced crystalloids, now pH guided resuscitation. I won't go into detail of this pH guided resuscitation, we can discuss it later. So this is one particular study in the post-transplant patient which I found interesting. The best fluid strategy, where they actually involved adults and children receiving a deceased donor kidney transplant, and they compared balanced crystalloid solution plasma light with a normal saline, And the primary outcome was delayed graft function, which was defined as receiving the dialysis within the 7 days post-transplant. Okay, so they compared two solutions, and what was the finding here? Compared with saline, balanced electrolyte solution was safe and significantly reduced the incidence of delayed graft function. We won't go into the dissection of this study. We can always look into it. But this is one study which actually says that plasma light is preferred to reduce the delayed graft function in a post-transplant patient. Similarly, a couple of other studies where they have used plasma light and they have found out that there is a superior post-operative graft function at 1 month and 1 year after transplantation. Another one study which says that there is increased incidence of hyperchloremic acidosis with subsequent hyperkalemia in normal saline, but the graft function and other things didn't change. Okay, so still the final message is crystalloids is a choice. If possible, probably a plasma light would be preferable, but RL will do the same thing. Then other common complication post-transplant we see is hyperkalemia. It is because of tissue trauma and resorption of intra-abdominal blood. And usually hyperkalemia more than 6 may necessitate dialysis, but if the output is very good, then you can reasonably manage with glucose insulin drip. Okay, and sometimes they use intraoperatively insulin dextrose, so you can have a rebound hyperkalemia postoperatively. So electrolyte monitoring is very important. Then this is something what we do nowadays is called as a ROSE. So you resuscitate in the first part few hours, actually you cause more fluid balance that is necessary to maintain the perfusion. Then eventually over the days, you have optimization phase and the stabilization phase, where in optimization phase, you actually maintain the fluids. You try to avoid the fluids in case of stabilization phase, and finally, lot of edema is there. You need to remove the fluids. That's where the de-escalation happens. That happens over the weeks. So de-escalation, we use diuretics and take the fluid out. Basically, we are trying to avoid fluid accumulation in the body to avoid the secondary organ damage. Same thing has been summarized in the slides. This is the different parameters. If available, it is fantastic. This is the invasive dynamic indices of hemodynamic monitoring. I'm sure Dr. Harish is very fond of all these numbers, but this is the way to go. But if you are not available, then I told you simple guidance like echo or the lactate clearance or CRT would do. Okay. Then coming to the infections, only one slide. You need to know the timeline of infections. You can't treat an opportunistic infection immediately in the beginning, So you need to know in the first month what are the common infections you expect is bacterial infections in the wound, lungs, urine or blood. So here, because it is highest immunosuppressive dose and non-opportunistic infections are very common in these areas, okay. In 1 to 6 months, CMV predominates 2/3 of cases, and after 6 months, it is Listeria, Nocardia and Mycobacteria. So always remember this CLABSI, CRBSI and COTI also happens in this first month during the admission to ICU. So this is the timeline very nicely summarized. This is the first month. You can see viral infection can be HSV and the other bacterial infections. And fungal infection, you can see Candida. Then between 1 to 6 months, you can see onset of CMV here. And bacterial, you have Nocardia, Listeria, and tuberculosis. Again, I told you wound infections, catheter-related infections, and pneumonia. Fungal, it is Pneumocystis and Aspergillus and Cryptococcus. Parasitic infections are strongyloids, Toxoplasma, and other things. And beyond 6 months, we have CMV, retinitis or colitis, papillomaviruses, all those. So that's how this is the timeline of infections and you need to be prepared for that. Okay. Rejection, I won't go into detail. Hyperacute, acute rejection, which can happen within 48 hours or within 1 to 6 weeks. And you need to know hyperacute rejection occurs within minutes to hours. Very rare, but it is untreatable and kidney is removed immediately. Acute it can happen anytime after the kidney transplant. And here you have the classical picture of high blood pressure, elevated serum creatinine, all those things. And here, basically, depending upon what type of rejection it is an antibody-mediated rejection or a cell-mediated rejection, your treatment also differs. Okay, and you need to do a biopsy and confirm that thing. Chronic rejection, I will not touch upon it. What are the risk factors for graft rejection and graft loss is? Female gender, again, advanced age, deceased donors, hypertension, diabetes mellitus, and prolonged cold ischemic times are known to cause delayed graft function, in turn attributing it to graft rejections. Okay. These are the immunosuppressants which we used, and I explained to you what are the complications of immunosuppressants. And so we do induction therapy, maintenance therapy. That is. So recently they have come with steroid sparing regimens, steroid avoidance, reducing the calcineurin inhibitors or avoiding the calcineurin inhibitors, and single drug regimens, which have been done so that we can avoid the problems with immunosuppressive agents, counteracting the infection part also. Okay. Then finally, we have something called, we have seen a lot of patients post-operatively coming to us with very high blood pressure post-transplant. And what are the causes for that? Again, we have immunological factors and the non-immunological factors. Immunological factors is, again, I told you when there is a graft rejection, there is high blood pressure or delayed graft function. Immunosuppressive drugs can cause high blood pressure, like calcineurin inhibitors and corticosteroids. Non-immunological factors, again, the donor factors and the recipient factors, and surgical related, like you give a lot of volumes or thrombotic or transport related arterial stenosis. Okay. So these are the different causes of hypertension. Also, you need to look for the blood pressure and blood glucose control, and the most important aspect is the nutrition. Okay, so this has to be taken care. Other routine ICU measures like DVT prophylaxis, all those things to be noted down. Finally, the most important part is you train your nurses well, you have a good outcome. So basically, maintain the asepsis, and you teach them about the immune suppressive medications, what ought to be looked out. Strict input-output chart, electrolyte balances, blood pressure and glucose control, pain management. I forgot about the one other cause for blood pressure high is pain. So you need to keep a watch on that. A good rehabilitation, physical as well as psychosocial rehabilitation is very important. And they need to know the warning signs, check the signs and symptoms of infection and rejection, and also when to identify the complications like sudden stoppage of urine, they need to inform. There is a bleeding from the dressing side, they need to inform. So if you have a good nursing team, if you train them well, then actually your life becomes much easier. So newer, some more advances in renal transplant, probably future is good, but these things doesn't make that you get an organ from the vending machine. Okay, so you need to actually create more awareness about organ donation, and that's how you can save more lives. So thank you for this opportunity, Dr. Harish and team. And if any questions, I'm happy to take.
Thank you, Dr. Himal, for that excellent presentation. I would like to know your thoughts on post-ATG induced capillary leak. Like, have you come across these patients, and how do you go about dealing with them?
So any good transport nephrologist, they can answer that question because I haven't come across it.
And just a comment.
Dr. Ram can answer that. Yeah.
I just had a comment. You will be the best intensivist if you understand that you are a pediatrician who has been babysitting a newborn child of your wife. You might be the father, but you might be a pediatrician, but your wife, that is a nephrologist, knows the best. Yeah. She's carried it for 9 months. We carry them for 9 years.
That's why I told you, you need to have a good nephrologist by your side and a good surgeon that makes our lives easier. And always befriend a nephrologist to have a good post-operative ICU outcome.
Yeah, and the other take was many a times in post-transplant settings, as you rightly said, patients are pumped with so much of fluid. But the next day morning, you can see some hemodilution, the hemoglobin has dropped, and then the surgeon is getting jittery. Then he wants n number of imaging to make sure that there is no bleeding happening anywhere. So, you just need to be cautious and judicious about how much fluid you're pumping into your patient. And as you said rightly, a daily weight charting of your patient would go a long way in preventing these kind of things.
Right. Agreed.
Any questions? See, in last week only, one of like intraoperative intensivist who manages both anesthesia and in the post-operative period also. She spoken to me like surgeon is insisting give 3 liter, 4 liter, no indices, no monitoring. You want to flush out the kidney. So she was asking, sir, what to do? Like, his only thing is you give fluid. I want to flush the kidney immediately so that there is no like microcirculatory problem, no graft related problem and all. No monitoring. So that's why like their only this one is take whether whatever you given, whether it is coming out or nobody is bothered. That is what we need to understand whether that particular patient during that scenario is he fluid responsive or not. Suppose you filled and all. If it is not coming out of the heart, it is like it is going to be get extravasated. So it's going to lead to all your breach in the endothelial glycocalyx and it leads to whatever the capillary leak. It may not be drug induced, it's just whatever the volume we given because of hydrostatic pressure and all. Basically intraoperative, my answer was okay. See, they are doing a very high-end procedure, including all advanced transplant and all. They need to invest on some modality of advanced
Basic
hemodynamic
modality,
monitoring.
yes.
So if they are able to understand during intraoperative period, so whatever they are giving, that is coming out of the heart or not. So that gives a solution how much to pour in the intraoperative period. That take care of your 40-50% of the problem in the postoperative era. So thanks for summarizing all those things, Dr. Himal. So I'll invite Dr. Venkatesh Gupta to hand over the moment to our speaker and chairperson. So last two lectures we have, after one lecture we can have tea break. So then we'll wind up with one more lecture. So last lecture I am not taking, don't worry. Yeah. Because we need to go home and celebrate the festival also. See, now we have two important some sort of organ interaction, I can tell, and what we need to take care of our organs when we go for some sort of renal supportive measures. So we are having Dr. Padmanabhan S, who is going to speak on like art and rationale of RRT in patients with liver dysfunction, advanced cirrhosis with ongoing AKI. I will invite Dr. Himal Dev, who is, I already told, is head of the department critical care medicine in Apollo Hospital, Sheshadripuram, and Dr. Sridhar Gidganti, so is the consultant in critical care medicine, Kaveri Hospital, Marathalli.
Presentations. Yeah. This is the slide. Right. How do I use the slideshow?
So, welcome Dr. Padmanabhan S. He is the Chief Nephrologist, Sagar Hospital, Bangalore, and he'll be guiding through ART and rationale of RRT in patients with hepatic failure and cirrhosis with acute kidney injury. Please
Thank,
go ahead, sir. Thank you.
thank you very much. It should be here. You go to presenters view. Copy it and paste it there. I'll get my laptop only. I have my laptop. So good afternoon. At the outset, I would like to thank Dr. Ram Mohan, Dr. Krishna Kishore, and Dr. Harish and his team for this invitation. So in the next 20 minutes, I'll try and see how I can cover this topic in the best possible way. So the problem at hand is that AKI is very common in patients with liver disease. Close to 40% of them get admitted to the ICU with AKI. But on the other hand, when we look at it, the prevalence of cirrhotic patients in an ICU is less than 5%. And out of those 5%, about a third of them require renal replacement therapy. And what is striking is that they have a very high mortality rate, especially if they are not listed for a liver transplantation. And what is the reason? The reason is that many of those with acute liver failure or acute on chronic liver failure do not come to the ICU because of perceived futility of treatment. So they just keep them in the ward and then manage them medically as much as possible. Now, I was intrigued when I saw the term art in this. So I was wondering why this was given to me. And then what I could think is that there is no consensus as of today as to when to initiate RRT and how to manage dialysis in all these patients. And then the prognosis of these people who develop multi-organ dysfunction is very, very dismal. So it raises the issue of futility of treatment. So maybe that is the reason why I was asked to talk about the art of renal replacement therapy in cirrhotics. So I'll give you three scenarios. These are very common that we see in the intensive care unit. We have a 50-year-old male with alcoholic cirrhosis with portal hypertension, admitted to the ICU with fever, circulatory shock, requiring stiff doses of NORAD, and spontaneous bacterial peritonitis was presumed to be the cause, started on empirical antibiotics after sending appropriate cultures, had to be intubated because GCS was very poor. Fluid overload was obviously there. Serum creatinine was 2 milligrams per deciliter. No previous reports are available. You have a very high ammonia levels. The patient remains oliguric despite optimal supportive therapy, and that is when a nephrologist is called in. Scenario 2, same as around 50 years old, HCV related cirrhosis, decompensated, listed for deceased donor liver transplantation, again developed an UGA bleed followed by altered sensorium and had to be shifted to the ICU because he became fluid overloaded and hypoxic, obviously intubated and ventilated. Progressive decline in urine output, anuric for the past 4 hours, received optimal medical management. Admission creatinine was 0.9 and has currently gone up to 3.5. No evidence of obstruction in the USG. Urine sediments were bland. So the diagnosis was HRS AKI, the old HRS type 1. So then the nephrologist was called in. Third scenario, it's again very, very common now. You have a 75-year-old male with cryptogenic cirrhosis, multiple comorbidities, circulatory shock, fever, altered sensorium, and then intubated, ventilated, anuric for 6 hours despite optimal fluid management. In addition to all these things, he has a low ejection fraction to start with, has chronic kidney disease with a baseline creatinine of 3. Now the creatinine has gone up to 5, has hyperkalemia, significant metabolic acidosis, fluid overload, and that is when a nephrologist is called in. So what are the questions that are posed to a nephrologist? Do we dialyze or do we not? If yes, what type of dialysis do we use? When do we start dialysis? We wait or we start straight away? Then, of course, anticoagulants, vascular access. But the most important thing for me is after all these things, when do we stop dialysis for this particular patient? So AKI is very common in patients with liver disease, and the etiology will almost be similar. You have pre-renal, you have renal, you have obstruction, post-renal, and only thing is IgA is somewhat very specific to people with liver disease, especially when they develop portal hypertension. Now, in addition to the increase in burden of AKI, there is also a simultaneous increase in the utility of either liver or simultaneous liver kidney transplantation. See, it has gone up 500% in the last 2.5 decades. We still have to deal with all these comorbidities because we are an aging population and we are a diabetes capital of the world. And we know that AKI leads to CKD, especially in liver disease, because it is very, very unlikely to recover completely. And on top of all these things, they have a 3x mortality, even if they do not need dialysis. And if they need dialysis, then the prognosis is very, very bleak. So we have to deal with all these things and then make our judgment and look at the graph. So this is people who are who had to be dialyzed, and this is those who did not need dialysis. And you see the vast difference. You have a significant 80% mortality in those who are requiring dialysis because of AKI in liver disease. So my first issue is whether I dialyze or I withhold dialysis in all these people. So let us look at the indications. This is something that we are all familiar in chronic kidney disease. These are the classical indications of dialysis. But these are slightly different when it comes to a patient who gets admitted to the ICU. So there you find that urine output becomes a major criteria. So people say that if you are oliguric for 12 hours, you dialyze. If you are anuric for 6 hours, you dialyze. Then they have host of other issues, dysnatremias, overdose, all these hyper things, plus all the classical indications come in. Now let us look at contraindications. So there is nothing called as absolute contraindication for dialysis. So everything is relative. But let us look at the middle two, advanced cirrhosis with encephalopathy and hepatorenal syndrome. So these are the list of relative contraindications for dialysis before, say, 1990s or 2000, when liver transplant was not very prevalent and neither was it very successful. So now that we are performing more of liver and liver kidney transplantations, I think we will have to have a relook at the relative contraindications. So this particular study was aimed to identify patients who would benefit from renal replacement therapy, both in the short term and in the long term. They used all the possible scores. I think these are all very familiar scores. I think generally most of the ICUs tend to use one or more of these scores. But what stands out is that if somebody has 5 or more organ failures, then the mortality is going to be 100%. So there is no point in giving dialysis for them. So, and this is independent of whether somebody has been listed for transplantation or not. So the question is that we have to identify a reasonable cutoff where we say that, look, RRT is going to be futile, it is going to cost you a lot of money, vis-a-vis the benefit that you are going to get because of starting dialysis in you. So again, very, very similar study. If you look at it, very high mortality if somebody is not listed for transplant. But on the other hand, you see a good number of persons went on to get liver or a liver kidney transplant. And once they go on to this, then the mortality becomes less. So we'll have to identify this particular population, and we'll have to be a little more aggressive when it comes to renal replacement therapy. So to me, what is the dilemma? Now, am I denying critical care to patients who might benefit from all these interventions? While I have to very keenly look at the high cost of futile treatment institutions in all these people. So this is where I need to balance. So to me, when I am called for dialyzing a patient with liver disease, it's probably the most challenging decision that I need to make. Most of them will have multi-organ dysfunction, and I mean, it is very obvious that the mortality is going to be close to 90%. We do not have very strict evidence to see what is useful, what is futile till now. So many scores are there. We can put all these scores have been tried, but none of them have come out 100% successful in prediction, except this one. When somebody has 5 or more, you get 100% mortality. Futility scores can assist, but it cannot replace your decision to whether to dialyze or not to dialyze. So we need to test all these scores in a very large cohort. I do not know whether it will be possible or not, maybe. And then we'll have to look at whether we need to do it early and whether we are removing all these PAMPs, DAMs, free radicals, whatever it is which we saw. So what are the practical points that I use when it comes to making a decision whether to dialyze or not to dialyze? The first one is whether there is a feasibility of a liver transplant. A living donor liver transplant is actually more favored than a deceased donor because the waiting period is always longer. We'll have to use any one of these scores and see what we are actually dealing with. And most important thing is look at the number of organ failures. I will not keep 5 as a sanctity. Even 4 or 3 will be reasonable. And then look at the feasibility of treating the triggering factor, because it is not that somebody has suddenly deteriorated. There has to be a precipitating factor, and more often than not, it will be an infection or a hepatorenal syndrome. So if we are able to identify a triggering factor, and if we feel that this triggering factor can be treated, I think we have to lend support to these sort of patients. And then if everything is difficult, then I would always give a time-bound trial. So let us support you. Let us give, say, 3 days or 5 days or a week, and we will keep reassessing. If things are not getting better, I think we should call it a day, because the cost is going to mount and the outcome may not be as good as we expect. So the second issue at hand is what RRT we should choose. So we have is intermittent hemodialysis, we have SLED, we have CRRT, and then we have peritoneal dialysis. Generally, I don't use peritoneal dialysis in an acute care setting unless and until there is no other option that is available. But it is still useful in infants and children where the regular dialysis machines may not support. And if somebody has got a high risk of bleeding, then PD will be a better alternative. It is easy to insert a catheter because all of them will have tense ascites. So one of the good thing is that PD becomes easy in all these people. But there is always a risk of peritonitis. The only thing I don't like is that solute clearance may not be as good as the forms of hemodialysis that we do. And then the most important thing is if somebody is in a shock, one of the things that happen is vasoconstriction to the vessels in the peritoneal membrane. So are we justified in doing peritoneal dialysis because clearance is going to be compromised further because of the vasoconstriction? So I will keep PD at the last. I'll skip this slide because I think all of us know the differences. I think we had a lot of discussion on regarding the CVVHD or CVVH or SCUF versus intermittent hemodialysis. This has been a controversial topic. As I said, it is not going to be sorted out because recruitment is a problem. There are a set of patients who are really very sick whom we cannot do the regular intermittent hemodialysis. We have to only do CRRT. And then For the rest of them, we do have IHT or CRT. So that is why you will find that whatever trial you take, you will find that there is no difference between the intermittent hemodialysis and the continuous renal replacement therapy. Same, I think this is what Dr. Jose discussed in the morning. I will not go into that. But what is interesting here in this particular study is that if we compare hemodialysis versus CRRT in those who are less sick, so which means a SOFA score of 3 to 10 are supposed to be the less sicker of the lot. Hemodialysis is actually better, and CRRT actually has a negative influence in terms of outcome in all these people. So basically, they said that CRRT as a first modality conveys no benefit over intermittent hemodialysis in terms of survival or renal recovery. And in those who have a less severe form of disease, it may be counterproductive also. So what are the pros for the CRRT? So I was telling in the morning that it provides better hemodynamic stability, and that is basically because of the heat loss and the hypothermia. We use a lot of fluid either as a dialysate or as a replacement fluid. More adequate fluid removal is possible, even though the removal is slower, but you can have net larger ultrafiltration compared to the intermittent hemodialysis. And then they say that recovery of renal functions would be better because we don't cause too much of hypotension in all these people. And it is more efficient in terms of removal of small and large molecules. But always keep in mind that all these filters are non-selective, which means it will remove things which we do not want, and it will remove things which we want also. So it is the balance between the pro and anti-inflammatory cytokines. So we will not know what we are removing. So cons, people have looked at hypotensive episodes between CRRT and intermittent hemodialysis, and they have found that the number of hypotensive episodes is no different, given the refinement of the machines and the methods of dialysis that we have. So the similar hemodynamic advantage can be obtained by cooling the dialysate. So we have that option. We can reduce the dialysate temperature. So if we reduce the dialysate temperature, we reduce the episodes of hypotension in all these people. And then the fall of MAP in intermittent hemodialysis is only 2.6 millimeters compared to that of CRRT. So I don't think that makes a great difference in terms of drop in blood pressure. But what is more important is that the cost is high. We need special equipment. We need trained personnel. It is labor intensive, and you'll have significant interruptions. And you need to give heparin continuously. And as a result of which, you can have a worsened bleeding symptom in all these people. So as I said, that we will never get an answer to whether you have to do CRRT or intermittent hemodialysis because of the inherent problem. We cannot recruit a certain subset of people into this because they are only for CRRT. And then many centers do not have facilities to do CRRT. So recruitment again is going to be a problem. So you will only find people getting recruited in centers which have all these things. They will be quaternary care centers. So it will not reflect. So basically, if I have to choose between that, given the fact there is no benefit of CRRT over intermittent hemodialysis, today nephrologists tend to favor SLED or this prolonged intermittent renal replacement therapy. We do it for 8 to 10 hours or maybe up to 12 hours. So the only thing is never hesitate to start intermittent hemodialysis in all these people, irrespective of whether they are on a single inotrope or a dual inotrope. CRRT is good in very specific instances. As I said, in patients with severe liver failure, it reduces the intracerebral pressure. So you don't cause a lot of harm in all these people. And if there are no cost constraints, if you have the equipment and the technicians available to do it, then I would lean in favor of CRRT in this group of people. And mind it, we have to use a bicarbonate based replacement fluid. What we have most of the times is a lactate based fluid, and lactate based fluid, if you use in lot, you will have paradoxical metabolic acidosis, which will compromise their hemodynamic status further. And bicarbonate based replacement fluids are pretty costly, so it adds to the cost. So when you have no cost constraints, when you have bicarbonate based replacement fluids available, then CRRT can be the option for these sort of people. So third issue, I will just quickly run through early versus late initiation. I think this debate will keep going on. My initial nephrology days, we never had CRRT equipment. We used to do CAVHD, and these filters used to be very small. So if you have a larger, a long filter, then it will clot very fast. So you should have that very small filters of this size. It's going to be very, very difficult. You'll have to sit there. You cannot leave that place. So then what we decided was we will use the pump. We used to use Cobe Sentry 2 machines. I'm sure people would have seen here. And those machines became defunct after some time. So we just took that hydraulic module, the pump only, and then we started doing veno-venous hemodialysis. That was actually much better than the CAVH. And subsequently today we have all the fancy CRRT machines which we can use. But whatever it is, the question is that when we were in the initial stages of nephrology, the rule is dialyze early. If you have a doubt, err in the side of dialysis. But today it is no longer true, because so we do not have any difference in terms of recovery of renal functions. That is one thing that we are always looking at. So a delayed strategy is actually much better in terms of preserving or getting the urine output faster. There is no difference in terms of mortality also. So better to start dialysis when there are reasonably concrete indications for people to start dialysis. So this is the criteria that this study used: a burn of more than 112 potassium. All these are all standard indications. And then when we use all these things, they said that RRT could be obviated in almost 50% of these patients, and renal recovery as assessed by diuresis was faster in this group. So I think I will also quit this. This is the forest plot which says there is no difference between early and late dialysis initiation, and mortality is almost the same. So as I said earlier, this is not a good idea anymore to err on the side of RRT. You use standard criteria for starting dialysis. This is slightly different when we use renal support versus renal replacement therapy. Renal support is predominantly when we use that for volume control and nutrition. Here we use more of ultrafiltration, slow continuous ultrafiltration. Always ensure that adequate medical management of chronic liver disease is done before you embark on renal replacement therapy. And I always listen to my gut feeling. It tells, look, don't delay, you just start dialysis. I start dialysis. I don't waver anymore. I think over a period of time, all of us will start developing this gut feelings. There is no scientific basis behind this. So basically, I'm not going to go into the non-dialysis management of patients with chronic liver disease. So this is what I'm going to concentrate as to what you should do. I'll show this much better in the next slide. So if somebody is listed for a liver transplantation and there is something that is reversible, always initiate renal replacement therapy, then periodically assess it. So if he or she is deteriorating despite this, then you feel that it is going to be futile, I think you have to stop that. On the other hand, if somebody is either not eligible or not yet listed for transplantation, then look at some areas where you can support them with renal replacement therapy to see whether we can tide over that particular insult which tilted the balance in them, and then you give them a trial of renal replacement therapy. If it is working well, then it is fine. If it is not working well, then we have to stop the renal replacement therapy in all these people. So the final couple of slides, when to stop. So these are very standard. Once the patient is clinically stable, there is resolution of the precipitating illness, improvement in the organ dysfunction, a spontaneous increase in urine output. They're able to maintain acid-base electrolyte and fluid balance, and there is a spontaneously decreasing creatinine. Then these are all indications to tell us that we have to stop dialysis. So what do I do? Yes, I look for clinical improvement. There is no standard cutoff of urine output. I always keep it on a slightly higher side to be on the safer side, because many of the times we send them out of the hospital. So I ask them to monitor the intake output, and the moment it crosses about 1.25 to 1.5 liters per day consistently without diuretics, then they come back to me. I don't dialyze them. I just do a serum creatinine, electrolytes, bicarbonate, check their weight, and make sure that these parameters are normal. So I don't want a weight gain, or if there is a weight loss, I know that there is a significant improvement in the urine output. So if good urine output, no weight loss, or weight loss or no weight gain, and then these things are all positive, then I remove the IJV catheter. I give 2 weeks time. If for 2 weeks somebody does not require dialysis, then it is unlikely that they require dialysis. Or if the serum creatinine continues to decline and drops to less than 2.5, I don't wait for 2 weeks, I remove the catheter. And then I continue weekly review till the creatinine normalizes. So once the creatinine normalizes, then the patient is discharged back to the hepatologist. So coming back to our case scenarios. So in the first case, what will I do? Yes, I will consider renal replacement therapy because we are suspecting spontaneous bacterial peritonitis and it is treatable. I will look at the scores of disease severity, look at the comorbid illness, look at the number of organ failures, and then would either suggest SLED or CRRT. SLED will be most of the times my criteria. The second one, I have not gone into all this Mars, SPAD, and Prometheus dialysis because it is hepatorenal syndrome. One of these things will help. A Mars will be useful if they have a donor that is waiting. So you have a living donor who's waiting, then we can just put them on Mars and then take them for a liver transplantation. Again, the same thing, look at the number of organs. The only thing is I would go with CRRT in this situation, but provided all these logistics matter. And finally, if the patient is affordable, I will use CRRT when it comes to hepatorenal syndrome. The third patient, he has everything for us to say, I don't want to go near you. So no RRT, but then you have a situation where the family wants to do everything for him. Now, it is very easy for us in India because the family pays for all these things. Whereas if you go to a country like Canada, US, where the government provides free dialysis for all of them, they have a big headache. If they say that you do everything that you want, then to establish medical futility is a huge headache. So for us, it is very easy. If the family wants, then I will say, okay, let us give it a time limited trial. And because he's on multiple inotropes, very poor cardiac reserve, CRRT, I would tend to fall on the side. I will tell the family very clearly that you have an underlying chronic kidney disease, there is an underlying liver disease, you have a very poor cardiac reserve, your renal reserve is going to be very, very poor. So the chance of renal recovery is very, very bleak. And you have to accept that there is a very high chance that if he recovers from this episode, he will have to remain on dialysis for life. And I always have to spell out that the mortality rate is going to be high. So this is where I practice nephrology. Thank you for your patient attention.
Thank you, dear sir. That was an excellent presentation. So calm and so composed. And the gut feeling comes with experience, that we know. So only one, before taking the audience question, intradialytic hypotension. I just saw the slide where it is almost not much of a difference between the intermittent as well as the CRRT. But I always thought it was more in case of intermittent.
See, if you look at it, all of these would be SLED, where you are able to get the pump speed down to 100. So you will never have a major hypotensive episode, because in CRRT also you're going to have 80 to 100. Less than 80, I think it's going to be hell of a trouble for us. So if you keep 100 as the cutoff, then I think the hypotensive episodes will be similar in both SLED and in CRRT.
Well taken. Any questions from the audience side?
So thank you so much for giving an overview. One of the organ issue, that is liver dysfunction, who need a dialysis and all. I'll invite Dr. Natesh to present mementos to our.
So while they're doing it, I can just a comment. Hypertension on dialysis is more to do with fluid removal rather than the blood flow. If you look at CVVHF, you need, the higher the blood flow, the better your filtration will be, and better your circuit life and filter life will be. So we look at something called as filtration fraction. If the filtration fraction is less than 20%, then the filter will last longer. The moment it crosses 20%, you will end up having a clotted filter or a clotted circuit. So CVVHD, you can run the treatment with very low blood flows. Yeah. But if you want to do CVVHD, so CVVHF or CVVHDF, you need a higher blood flow to achieve a lower filtration fraction. So why is it that people with CVVHDF or CVHF, even though you're having a blood flow of 150, or in the West, if you go, they're running it at 200, they don't have hypertension. Yeah. So it is the fluid removal, not the blood flow.
We'll invite now for the last lecture of today's session. Again, definitely is going to be very interesting, because this is what we face as a real challenge when you have a high-end multidisciplinary ICU, when we get lots of patients with head injury, stroke, and they'll end up with some sepsis down the line, raised ICP with acute kidney injury. We'll invite Dr. Krishna Kishore, Dr. Karan, Dr. Jason George to chair the session. We have speaker Dr. Rohan Agustin, who is a consultant nephrologist in Manipal Hospital and is also a transplant physician and the lead there.
Yeah, it's indeed my great pleasure to introduce my esteemed colleague of Dr. Rohan Agustin. Dr. Rohan works as a consultant nephrologist in Old Airport Road, Manipal, and his keen interest is in critical care nephrology and interventional nephrology. I'm sure that we're going to have an academic feast now with Rohan talking on AKI in patients with stroke and acute brain injury. Over to you, Rohan.
While we just get started at the outset, let me express my sincere gratitude to the team at Kaveri, including the intensive care and the nephrology team led by Dr. Ram Mohan Bhatt and Dr. Krishna, my good friend. And it's indeed an honor. It's indeed an honor and privilege to be with you all this evening. More? Yeah. This is. So the mandate that I have for today evening is the intricacies of RRTs in patients with acute brain injury or stroke. So the overview of my talk would be, I would begin with just a brief about the magnitude of the problem that we are dealing with. Then the incidence of acute kidney injury in patients developing acute brain injury, the mechanisms of acute kidney injury in patients with traumatic brain injury, cerebral edema and the rise in intracranial pressure, challenges in doing dialysis in this particular category of patients, dialysis modality of choice and why, suggested modifications to the RRT for neuroprotection, and compatibility of the CRRT with the osmotherapy that is co-administered many a times, and finally I would draw my conclusions. So to set the context, this is a 19-year-old male who is admitted to the critical care with traumatic brain injury, sustained multiple fractures and a subdural hemorrhage. He has raised ICP to begin with, and the good neurointensive care has managed to bring it down with standard neurointensive monitoring and SDH evacuation. But however, several days into the course of his illness, he also develops hyperkalemia, acidosis, secondary to severe rhabdomyolysis, and warranting the initiation of RRT. So situations like this is not very uncommon in day-to-day practice, and this is what we set out to learn today. So acute brain injury, as we all, So traumatic brain injury is a major cause of admissions to hospitals and also causing death. So the mortality rate here we are talking about is somewhere between 30 to 50%, and about 5 to 10% of them may become permanently vegetative or severely disabled as well. And in the European neurotrauma study, they found that almost 50% of these patients needed ICU, and almost 40% of them who entered the ICU also had multiple other comorbidities in the form of systemic diseases, and 25% of them were older population of more than 65 years. So if you look at the incidence of AKI in this category of patients, in the center TBI study, they said within the entry to the ICU in 72 hours, 12% developed AKI. In another study, that the EPO TBI study, the percentage was pegged at 16% during the first 3 weeks of ICU stay. Australian studies scored an incidence of around 9, and Americans scored an incidence of around 3. So give and take, anywhere between 5% to at least 15% will easily develop AKI during their hospitalization. And the majority of the traumatic brain injuries are many a times younger individuals, wherein they have normal kidneys to begin with, and they most of the time have only AKI. Whereas ischemic and hemorrhagic strokes are more common seen in older population, and these patients, the risk of AKI would be much higher, going up as high as 14 to 21%. So why do they develop AKI? Obviously, there are multiple factors that are playing a role here. Here you have when someone develops a traumatic brain injury, obviously there is trauma, hypotension, they may go into sepsis, they may develop rhabdomyolysis and go into toxic ATN, there may be multiple drugs that are administered, uncontrolled hypertension contributing to malignant hypertension and acute kidney injury, hypovolemia, and so on and so forth. So the parts of both these intersect, and the end result is a perfect storm that is then going to set in. So once you have a brain injury, obviously there is the onset of cerebral edema, and this cerebral edema will set in and reaches its peak by around 48 to 72 hours. And this cerebral edema is broadly classified into two groups. One is the cytotoxic edema, wherein you have changes in the brain cells, that is, the cells swell because of changes in osmoregulation, but the blood-brain barrier is intact. And the vasogenic edema, in which there is a disruption of the blood-brain barrier and leakage of plasma proteins and albumin into the brain substance. And in clinical practice, many a times, both of them occur concurrently in the single patient. So just a cartoon to depict the same thing. The cytotoxic edema, wherein the vascular endothelium is intact, and the vasogenic edema, where there is a disruption of the integrity causing the cerebral edema. So the key to maintaining somebody who has had an acute brain injury, obviously every intensivist should know that you want to maintain good oxygenation. And if you work it backwards, that cerebral oxygenation is contributed by a cerebral blood flow and the oxygen content that is there in the blood, which in turn is a reflection of your oxygen saturation and hematocrit. So if you look at cerebral blood flow per se and work it backwards, the cerebral perfusion pressure is what directs or what drives the cerebral perfusion. And this is the difference between your intracranial arterial pressure, or in other words, your mean arterial pressure, and the intracranial cerebral pressure, which is contributed by three components: the brain volume, the intracranial blood volume, and the cerebrospinal fluid. So this forms the crux of whatever I'm going to talk subsequently, that when you're dealing with these patients, you're trying to maintain cerebral perfusion pressure, and you're doing that by maintaining reasonable map and making sure that your ICP is not going too high, so that you do not drop the cerebral perfusion pressure. So as long as you get this concept right, you would understand what is going to happen next. So once the brain has an injury, obviously there is cerebral adaptation. So what the brain essentially does is, you have three components in a fixed structure: so your brain, CSF, and blood. So if the brain volume is increasing due to edema, then obviously the CSF gets shunted into the spinal cord, and that's called as craniospinal buffering, which happens initially. And many a times in neurointensive ICU care, you always see patients being kept upright to facilitate the same process. This craniospinal buffering is more adept if it happens in an acute setting, in a chronic setting, but not so much if it happens in an acute setting. So the basic goals that you are dealing with is, we need to decrease the cerebral volume. We need to maintain the map of at least greater than 75 mm of Hg, maintain a cerebral perfusion pressure of greater than 60, and maintain cerebral oxygenation. So these are the broad outlines of what you're trying to set about while dealing with a patient with acute brain injury. And these are the standard things that are followed in neuro ICU, that is head up positioning, moderate hypothermia, maintaining a map of about 75, electively intubating and ventilating your patient so that you're maintaining oxygenation and you're also delivering mild degree of hypocapnia, sedation and paralysis as the need may be, CSF drainage, barbiturate induced coma, decompressive craniectomy if needed to reduce the ICP, and osmotherapy, which we'll be talking to subsequently. So I would now digress from the rest and now come to the topic per se. So what are the challenges in dialyzing someone with acute brain injury? So conventionally, even in outpatient hemodialysis population, when we do dialysis, it is well documented that it produces an increase in brain water content, even in regular, stable, healthy patients. And the second important challenge that comes in these patients is that the extracorporeal anticoagulation that we may want to use would potentiate to further hemorrhage. So why does intermittent hemodialysis cause an increase in cerebral edema? And there are four different hypotheses to put forward. One is what we call the reverse urea effect, which I'll come to. The second is the idiogenic osmol hypothesis. Third is a paradoxical intracranial acidosis. And fourth is the intradialytic hypotension that can sometimes happen, reducing your MAP. So in this cartoon, I just want you to first remember about this particular formula. It's quite familiar to all of you all. So the serum osmolality is driven by your sodium and your blood urea nitrogen. So if you're going to do a dialytic therapy and reduce your BUN, obviously it would be associated with a reduction in serum osmolality. And that is what you're doing in here. So you have a capillary here, and as dialysis starts and urea starts moving quickly across into the dialysate, you have a sharp dip in the urea concentration and associated with a decrease in urinary on the serum osmolality. So the movement of urea from the cerebrospinal fluid and from the brain is not as robust as it happens from the intravascular compartment. And the end result is you're going to get an osmotic gradient in the opposite direction. So the brain is much more hyperosmolar now. There is increased generation of idiogenic osmos, and the movement of water now from the capillaries into the cerebrospinal fluid and into the brain. And the end result is that you're producing cerebral edema. And this concept is what we refer to as the reverse urea effect. The next two the causes would be, one is the idiogenic osmol hypothesis and paradoxical intracranial acidosis. Now, what do we mean by this? So as we start dialyzing a patient, essentially the acidemia is taken care of and the patient's pH actually starts rising and the bicarbonate in the blood actually goes up. So while the patient's pH is actually rising and the patient acidosis is getting corrected, what we see is because of the rise in bicarb by Henderson-Hasselbalch equation gets converted into carbon dioxide, and carbon dioxide then diffuses into the cerebrospinal fluid and into the brain, and then generates further H plus ions and drop in intracerebral pH. So the blood pH is actually coming up, but the pH inside the brain is actually going down, and that is what is called as paradoxical intracranial acidosis. And the end result of this acidosis again is that it breaks down phosphates and generates multiple idiogenic osmoles, which further produces more cerebral edema. And it is well documented that when you do dialysis, you can have a surge in intracranial pressure in the first 1 hour, then it may plateau out, and then towards the end, it may again go up. So it's just not the change in osmolality or the change in pH that is driving this. It can explain the late peak, but it probably would not explain the early increase in ICP. And a part of that early increase in ICP is probably the hypotension or the mild dip in blood pressure that happens at the start of dialysis with the release of local vasodilators, and the end result is compromising your MAP. So this is the chart just to show that the MAP may transiently dip, and that's associated with an increase in intracranial pressure. And then towards the end, again, you may see a mild increase in intracranial pressure during a intermittent hemodialysis session of 4 hours. Next, what dialysis modality we choose and why? So while considering a dialysis modality, one thing that we look forward is, I already told you what urea is the one that is coming down quite drastically and producing the cerebral edema. So what is the rate at which urea is removed by all these modalities? So as mentioned, intermittent hemodialysis is the most potent in terms of urea removal at the end of 1 hour of dialysis compared to CVVHDF or CVVHF, and the least with peritoneal dialysis, which was enumerated earlier in the talk. So you have the maximum fluctuation in urea with intermittent hemodialysis. If you look at the change in if you look at the change in urea clearance overall, again, the urea clearance is maximum with intermittent hemodialysis and in the mid-range with CVHDF. And if you look at the urea clearance per day, again, if you took at the overall clearance in 24 hours, CVHDF would be performing better. So here you have CVVHDF as a modality which would give you slower urea removal, but much more solute clearance over 24 hours without producing the osmolar shifts that we are obviously worried about. And added to that, the benefit of hemodynamic stability, which is well known. So given all these factors, having understood the pathogenetic mechanisms and the benefits of each therapy, KDIGO then goes on to recommend that we suggest CRRT rather than intermittent RRT for acute kidney injury in patients with brain injury, especially those who have raised intracranial pressure or generalized edema. And that is also depicted in this slide if you look at the intermittent hemodialysis, wherein you can see the change in intracranial pressure versus CRRT. So CRRT has shown greater intracranial stability. The changes in osmolality and urea and bicarbonate levels are much less. And if they run successfully over 24 hours, many times they are interrupted, then the total clearance that you get is superior to intermittent modes. And it is also associated with improved cardiovascular stability. Now comes to certain modifications that we use in our inherent patients. So obviously when you're doing CRRT, you do not want these patients to drop their MAP. So you're starting slow with a low blood flow and then gradually increasing a blood flow if they remain hemodynamically stable. So consider the use of low blood flow rate. Second, consider priming the circuit with either albumin so that you do not produce that initial hemodynamic instability when you just start the renal replacement therapy. Third, avoid high ultrafiltration rates. Again, as Dr. Ram earlier mentioned, you do not want ultrafiltration and upset their hemodynamic stability and thereby reducing their cerebral perfusion pressure. Next, you make sure that you have a higher dialysate sodium or a replacement fluid sodium. And as I mentioned in that equation, sodium is the other player that maintains serum osmolality. So you do not want the sodium to drop down. You maintain a higher serum sodium. Use a lower dialysate bicarb or a replacement fluid bicarb concentration. And since anticoagulation is an issue, regional anticoagulation would be the best as far as brain injury is concerned. Now, is it an absolute no-no that you can't use intermittent hemodialysis? That's not the case. So if you have a patient who has got very minimal brain injury, there is not significant vasogenic edema, no midline shift, and you are in a resource limited setting where you don't have access to CRRT, you could still probably use intermittent hemodialysis. But as a treating doctor, probably these modifications would help you in dealing with these patients better. So here again, you use a lower blood flow and a dialysate flow. So do not produce too much of osmotic shifts. Use a smaller dialyzer. Use a shorter treatment session type. So just use it for 2 hours. You can always come back and do it again the next day. Use a higher dialysate sodium for better hemodynamic stability. Try to lower your bicarb from standard 35 to 30 so that you do not produce a rapid increase in arterial pH. If you can cool the dialysate, nowadays dialysis machines provide for that facility, so try to cool the dialysate. Avoid high ultrafiltration rates and use regional citrate anticoagulation. And many a times we nephrologists, at least in our center for chronic patients, whenever we are doing our first dialysis, we sometimes use intradialytic mannitol as well to reduce intracranial pressure. And consider frequent hemodialysis to maintain the bun at the lower range and to minimize the change in BUN and osmolality. So these are the modifications that you would probably prescribe in a patient wherein you have no facilities for CRRT and probably you need to get away with IHT. Now coming to PD, most of the times in current critical care ICUs, we rarely use PD as a modality because as I just showed, it produces the least urea clearance, but although it is good at maintaining intracranial stability. So stability is not the issue here, but the overall net clearance that you get would be poor. Second, in a setting wherein someone is very hemodynamically unstable, if you're going to use peritoneal dialysis, your clearance would be even more worse. But if you're using PD, few modifications that you can do, that you avoid instilling large volumes into the peritoneal cavity because then you would be compromising your pulmonary function. You would be reducing your oxygenation and your net, there will be a net reduction in your PaO2. Next, when you're draining it out, do not drain it out completely because that would again produce cardiac instability due to variations in cardiac filling pressures. And many a times they recommend to do tidal dialysis. So tidal PD is one wherein you leave behind some amount of fluid in the peritoneal cavity and then start the next fill. So you do not drain the peritoneal cavity completely, retain some fluid in and thereby maintaining cardiovascular stability. Now comes to anticoagulation. So obviously we do not want anticoagulation in these patients, and if you're doing short intermittent hemodialysis of 2 hours, you would probably get away with saline hemodialysis as well. But the problem comes when you're going to use CRRT as a modality and anticoagulation free, obviously you're going to clot your filter off, especially if your filtration fraction starts crossing 20%. Therefore, one trick of the trade that you could use is you could use the replacement in the pre-filter mode or the pre-dilution mode so that the dialyzer is not getting excessively hemoconcentrated and doesn't clot. And if anticoagulation is needed, then probably the most effective anticoagulation would be a regional citrate anticoagulation. And to note that the trisodium citrate that you use for citrate anticoagulation also adds to the sodium load delivered to the patient, which I would be coming to in my subsequent part. Now, timing. So, in general, if you have an acute brain injury or stroke, unless there is no urgent indication for KRT, it is beneficial to avoid hemodialysis for the initial 24 to 48 hours after the acute brain event. However, there are some observational studies which say that the higher the pre-initiation bun, more is the chances of fluctuations in the ICP during renal replacement therapy. There are a lot of articles written by Davenport, if you would Google, who suggest that you should try to keep the RRT early to prevent a significant rise in bun. What is the optimal pre-dialysis level of bun to minimize the rise in ICP has not been investigated, but expert opinion says that you try to keep it below 30. That's what they recommend. Next comes to the question. Many a times in neuro ICUs, you would see that to reduce intracranial pressure, the neurosurgeons or the intensivists want to maintain the serum sodium between 150 to 155, and here you are running CRRT, which has a replacement fluid sodium of around 140. So how do we go about satisfying both the groups and maintain the sodium at 140, 150 to 55, but at the same time carry on with our CRRT? So you have to understand that what sodium goes into the patient in a critical care patient in undergoing CRRT depends upon 4 solutions that you are using. One, your anticoagulation contains, if you're using citrate, then trisodium citrate would give you around 224 milliequivalents per liter that is infused. If you are using replacement fluid, the commercially available fluid that we have is 140 milliequivalents. You don't get fluids with lesser sodium. The intravenous fluid that is continuously going for antibiotics and various other things in the ICU stay, that would deliver around 154 milliequivalents of sodium per liter. And if the intensivist wants to use hypertonic saline, then that would be delivering another 513 milliequivalents of sodium to the patient. And this can be used infused peripherally as well. So These are the four solutions that are there, and you have to play around with these four in order to deliver the sodium that you are getting to your patient. So if you need to achieve this, you can't fiddle around much with the trisodium citrate except for the rate of infusion. Your replacement fluid is generally fairly fixed because there's one sodium 140 you can't alter. So basically what you have to play around is you have to play around with your 3% infusion rate. And how do we do that? Now just giving you a scenario, I'm not sure if it is clear. So as I said, citrate. So citrate contains 224 milliequivalents per liter and it's running at 250 ml per hour. So if you do your math, this is delivering 56 milliequivalents of sodium. If you look at your replacement, it is 140 milliequivalents per liter and you're infusing it at 1000 ml. So that is delivering 140 sodium. Assuming that you're not using 3% sodium chloride, it's zero. And if you're using IV fluids, you're delivering 0.9%, so that is 15 milliequivalents per hour. So the total sodium is 56 plus 140 plus 15, that is 211. And the total volume that is infused is 250 plus 1000, nothing in 3% and 100 ml per hour. So that is around 1.4 liters. So the net sodium that you're finally delivering to your patient is around 157. So this is just a nomogram wherein you can choose your replacement fluid rate as it goes up, and you can make suitable adjustments to your 3%, but making sure that your net sodium that is delivered to the patient is kept at around 150 to 155. A similar example wherein here you are increasing the rate of citrate, 250 now became 300. So the delivered sodium here goes up to 67 and the rest remains the same. But the concept is the same, that you add the sodium that you get from citrate, from the dialysate, from your replacement and for IV fluids, and the end result divided by the total volume that's going in per hour, and that's what is the final sodium delivered. And you could also do it without using any citrate. If you are doing citrate free anticoagulation, then the calculation would go similarly. So in our case, in order to prevent the development of this osmotic gradient, and to make sure that we clear the myoglobin, which is a middle molecule, we decided to go with CVHDF. So it was a replacement fluid was with a Prismaflex used pre-filter, and there was a separate post-filter infusion of 3% sodium chloride, with the serum sodium being monitored every 3 to 4 hours. And with this, we were able to perform CRRT without adversely affecting his ICP. But unfortunately, he deteriorated, had worsening PO2, and now becomes very acidotic. So despite being on CRRT. So here again, you could juggle around with your fluids. So the patient is in severe respiratory and metabolic acidosis. So the patient was intubated, ventilated, and because of metabolic acidosis, the 3% sodium chloride was then changed to a bicarb infusion. And the concept being the same, replace the 3% with replace soda bicarb with 3% sodium chloride. And the sodium delivered is the similar calculation that I showed you earlier, and thereby you can still correct the acidosis and maintain the serum sodium at 150 to 155. So these are a few hacks that you would do to maintain the serum sodium and prevent rise in ICP. So in conclusion, performing intermittent hemodialysis in patients with acute brain injury is associated with the risk of worsening cerebral edema, and we as nephrologists or intensivists should be quite familiar with modification of these prescriptions so that we offer the best therapy to our patients. With those few words, I would like to draw you to this whole nomogram, wherein if you have an acute brain injury, first assess is there an acute indication to do dialysis. If not, preferably avoid in the first 24 hours. If there is cerebral edema, midline shift, the patient is hemodynamically stable and altered, then probably CRRT would be the best option. If not, there is no midline shift, patient is very stable, you could still consider intermittent hemodialysis. And the 8 hacks that I mentioned, low blood flow,
Thank you, Rohan. That was an excellent talk. It's only fitting that the day-long academic feast ended with a good dessert. Thank you very much. Over to Harish.
Questions?
Rohan, excellent talk. It's just a shame that many more couldn't hear your talk. As Kishore said, it had everything from physiology to bedside. One question. So the citrate anticoagulation bags that we have are all preformed. We don't use TCA, and both Regiocit and Bifossil will have 140. So that means you'll have to depend more on your 3% saline.
Calculation right, you can obviously adjust your fluids around.
If you have a chart, you just give it to us.
Sure. And the other thing that I didn't mention, I mean, it would be beyond the topic, is the many a times you would also have cerebral edema. You would have what is called SIADH, or cerebral salt wasting, in the setting of an acute brain injury. So there the sodium is very low, and then you need to correct it up. So there again you can juggle around with your fluid. So you have a 5-liter bag, you pull out 250 ml and replace it with 5% dextrose. So by doing that, you can lower 140 to 133. You can create another bag, pull out 500 ml and replace it with 5% dextrose. That will bring the sodium down to 127. You remove 750 ml and replace it with 5% dextrose. You would bring down the sodium to 119. And you do it with 1 liter replacement, you would bring it down to 112. So you start your CRRT with 112, the bag that contains 112. Wait for the patient to reach 112 and stabilize. Then you switch to a bag which has 119. Then switch to 125, and then switch to 136. So
But would you do this in a laminar flow hood, or all these things, because you're going to
The other simple way that we do in this is you just infuse 5% dextrose simultaneously and make sure that you don't overshoot your correction.
Thank you.
You also want to keep the sodium at a higher level just to prevent that cerebral edema, is it not?
Yes.
So how long you're going to maintain that? So because that's always a debate that we have with the neurosurgeons now. They'll just not allow us to top the 3% saline and keep it on flow for a longer time. So when do you think we should be
I
stopping
think
that?
in neurosurgery, they believe that at least a week, they want the sodium to be high and only then lower it down. So that's what they do.
Yeah, when it comes to 3% saline and all, see, they are not like agreed to give a very good dosage. That is the problem. They give us some Ayurvedic dosage, like 20 ml per hour. So neither it's going to serve the purpose in relation to timeline. See, when it comes to anticerebral edema measure, it's an acute therapy. If you continue 20 ml, 10 ml per hour, it doesn't mean. And most of the time, those patients whom we want like anticerebral edema measures, even if you give a bit high dose, they will tolerate without any problem, like what we do for correcting hyponatremia, kind of stuff. And whatever we get like with the commercially available citrate anticoagulation and all, I think it's a low concentration. Yeah. So it's not going to be a higher one. So I think our understanding for any patient with a neuro insult, modality is CRRT, anticoagulation is citrate. But only thing is sodium we need to take care with an add-on 3% calories. So that serves the purpose. Thank you all. So I'll request Dr. Ram to hand over. So please join us for one group photo last. All of please. We have key also.